Stephen, I can't hear you. I can't hear you.
Let's unmute. Can you hear me now?
Yeah.
Marvellous. Okay, so I was just saying, today we've got quite a bit to go through. We've got 7 subjects, I think. So we'll start straight away. Obviously, the first subject which you can see on the screen is working with people with dementia. So the youngest person to be diagnosed with dementia was Jordan Adams, and he was 23 years old. So he's the youngest person to be diagnosed with dementia in the UK. There's currently more than 42,000 people in the UK under 65 who has dementia. So therefore, we know it's not just associated with the aging process. Some people with dementia who are under 65 as a young person is known as young onset dementia. And what we know about younger onset dementia is the younger you are, the faster the onset starts to become, so those signs and symptoms become a lot more prevalent. We're not going to cover all of that, because that's just all those bits. So, the aims of this session is to understand dementia, know how it affects individuals in the health and social care setting, and to support people with dementia. And I know through some of the other sessions we've done, we talk about dementia because I think it's a field that we're all familiar with. So again, as we go through this, by all means, if you want to talk about some experiences, feel free. So first of all, let's just think about our thoughts and feelings around dementia. When I say dementia, what are your first thoughts? Are they positive or negative?
Negative.
Negative, okay. Anybody else?
Negative, yeah.
Negative. Yeah, and that's because there seems to be a lot of stigma still attached to dementia. And for us who work in the industry, we see it as quite a challenging mental health condition, don't we? Which then kind of leads us into the fact that there's still a lot more work as a society that we need to do to improve people living with dementia. And there's a lot more work in which we can do. So reducing stigma, there are currently about 850,000 people living with dementia in the UK. Each have their own unique qualities and their own life stories. And we need to be thinking about how we as individuals, as healthcare professionals, how we can support the reduction of stigma. And the reality is, I think we all have that kind of belief that if we were to get dementia, we would be making our own life choices quite quickly. And we'd be looking at kind of probably some advanced decisions there. So we need to reduce some of that stigma because, again, I think a lot of people with dementia, they talk about people being crazy or, you know, there's just that negative thought around it. So we do have a fair amount of work to do. And the way we start by doing that is just by being a bit more positive about it. So rather than saying the word suffering, we use the words living with, you know, because the reality is we don't know if people suffer, but we can say, you know, you can live well with dementia, and we need to start looking at more of the positives around it than necessarily the negative aspects. And that needs to come across when we do our care planning. It needs to come across when we're talking to relatives and to family members. And we need to be thinking about how it sounds back to us. So if we're talking about dementia, are we using a language which is a bit more inclusive and supportive? So there's some phrases here in which obviously you can do, always use language that recognises dementia, and that's not a defining aspect of the person's life. So see the person, not dementia. So when we talk about people, we shouldn't be labelling this person is living with dementia, that's not the main fact of this person. What we need to be looking at is their strengths and what they are able to do for themselves and be a bit more positive around it. And equally, we need to be looking about the way in which we empower people to make choices around their life. So we just need to be a bit more thoughtful around the language in which we use, especially the written and verbal. There's also some important basic principles to follow when writing about dementia. So when you're telling somebody's story, use their own words as much as possible. So this is when we're doing that personal centered care plan in writing. If we're talking on behalf of somebody, we should be talking about them with their own, in their own way, in their own language. And obviously dementia affects everybody differently, and everyone will express their experiences of dementia in their own way. Now, have any of you done the Dementia Friends training?
Yes.
Yeah, and actually some of this is going to link quite nicely to that. Has anyone else done Dementia Friends training?
No, not yet.
No. Okay, so it is one of the things on the module. When you go into Canvas, there is a link to become a dementia friend. And the way that they describe dementia as a dementia friend is, imagine your brain as an empty like fishbowl, and inside it is Christmas lights. And those Christmas lights are all the neuro pathways. So it's all those memories and thoughts. Basically what happens with dementia is those lights get turned off one at a time. And it just changes the way that that person may act, think, speak. And later, when we look at the anatomy and physiology of the brain, depending on where those lights are being turned off, we tend to know what the behavior is going to look like, or what the symptoms might look like. And therefore, it can't be the same for everybody. Everybody experiences dementia in a very different way. And equally, as we look for that, when we talk to the family members, we need them to be a bit more positive and a bit more understanding about it, because when we come to the end, we'll talk about the bookshelf. And I think the bookshelf is a really nice way of saying to family members about the importance of love and care, because whilst they forget the now, that emotional regulator is still there. Those feelings of safety and security are still quite present. And actually, we see that a lot in the care that we give, because if you are a kind, caring person, you tend to be the one where everyone flocks around you. You're the one that the patients normally go to. You're the first go-to person. Or if you've got somebody in distress, you're the one that walks in the room and brings them down. Now, it may be the fact that they don't recognize you, but what they recognize is that love and that warmth and that feeling of safety in which you bring. So we know that even with dementia, the memory's gone, but the emotional regulator bit is still very much intact. So, and that's why you tend to find people that are very compassionate and kind and caring, that project that, work really well in dementia, because the person that's the receiver, and if we look at Sharon and Weaver's communication methods, that receiving is kind and warmth and love. So family members need to kind of understand some of that. So don't use the following. Obviously, avoid any language which is negative. So, you know, like we've already said about suffering, wandering. We don't like the word wandering. We're normally walking with a purpose. If people are doing something which is a bit of out of the ordinary, let's look at why they're doing it rather than label it, oh, that was a stupid thing to do. So for example, if we entered the world of dementia and you saw somebody putting things in a washing machine, like their cups and plates in a washing machine, maybe that's because in their day they didn't have a washing machine and they just think it's a cupboard. So actually, by understanding the behavior, we can avoid some of those negative things. And what you tend to hear family members can be quite derogatory in the way that they speak about it. Oh, my mum's just stupid, or she never used to do that, or oh, mum, don't do that, that's a silly thing to do. And actually none of that's really helpful, is it? So again, it's just about us working around that. So what do we already know about dementia? What do we already know as a group?
Is a damage in the brain?
Yeah, so parts of the brain could be affected with it. Yeah. What else?
We got a lot of confusion and lost
Short-term
forgetfulness.
Yeah, so short-term memory, bit of confusion. Anything else?
Lost sometimes.
Yeah, so lots of things to do with that memory and those feelings. So ultimately, by the end of the session, you're going to know the different types of dementia. You should be able to identify the different types of dementia by the end of this session. And you should be able to identify some of the causes of dementia as well. And a recent study has come out at the end of last year about brushing your teeth and good oral hygiene. And poor oral hygiene leads to the proteins into the brain which affects dementia. So poor oral hygiene can contribute dementia. It's one of the underlying conditions that's come out. So the plaques, the proteins that build up in the mouth can obviously cause further problems there. So dementia is not a disease, it is a condition caused by a disease. Dementia is the name of the group of the symptoms that include what we've just said: memory loss, difficulties with thinking, and sequencing. So when we think about the things that we do, everything we do has a sequence from A down to Z. You know, if we're making that cup of tea, there's multiple stages that we do in that. Dementia is caused by the disease that affects the brain. The most common is the Alzheimer's disease. However, there are many causes of dementia that affect people differently. Dementia is not just about memory loss, and many people with dementia will have memory loss, whilst some people may prefer to speak about memory problems rather than the dementia. We should not use the two systematically, as they can exclude people in other ways, dementia or people who have other different symptoms. So when we think about the causes of dementia, what can cause dementia? What can cause dementia?
Excessive drinking.
Sorry?
Excessive drinking.
Yeah, so corn cough, dementia.
Stress.
What did we say there?
Stress can cause dementia.
Yeah, so long periods of mental health problems can eventually cause dementia. Others? What happened to Margaret Thatcher? Why do you think she ended up with dementia? Margaret Thatcher, she used to only sleep 4 hours a night. So the brain is a muscle, and if you don't turn that brain off, if you don't rest that brain, and if you don't get peace and quiet, eventually it fatigues. So we've got poor sleep.
Steve,
Yeah.
sorry, there's a lot of interference. I can't really hear you.
Okay, let me just.
I don't know if it's just me or someone else.
Anyway, what I'll do is I'll mute it all. There you go. Hopefully that's better. So with Margaret Thatcher, she obviously had poor sleep, minimum of 4 hours a night, or maximum of 4 hours a night she was getting. So the brain was never resting. So we know if the brain doesn't rest, that's an underlying cause. We know genetics plays a cause in dementia. So again, it could be hereditary. We've said substances, so not just alcohol, but drugs. Acquired brain injuries. So if we have a frontal lobe injury, normally caused by car accidents, if we hit our head front on, that can cause underlying problems with dementia. And equally, we now know through other things such as illnesses, infections, and things like that can trigger causes of dementia. So lots of causes there to have a think about. As I said earlier, dementia is unique to each person. And we've explained, obviously, if you think of that's your brain, and this is a nice way to explain it to family members, those lights get turned off and those lights just affect different things. And there's no particular order on what light gets turned off first. But each of those will be either a movement, a word, a memory, you know, sight, sound, smells, or whatever. So living with dementia, I'm not going to play this video. No, actually, I will play this video because it's quite a nice video. I don't know whether it'll play. Let's just see if it plays. No, it's not going to play, is it? Oh, no, it is going to play. Just let me know if you can hear this. Can you hear that?
Look at those hands. I still feel like I'm 18. But then I think I've been 18 for a while now. Oh, I'm here again. I recognize some of my favorite pictures. Oh, something's changed. Concentrate. Oh, perhaps not. Now, I recognize this picture. It's, oh, who is it? The faces seem so familiar. So familiar. Why is it dark? I don't remember going to bed. What's that? Voices? Alison, is that you? Count sheep. Go to sleep. Count sheep. Count.
Hi there.
Who's this? What's he doing in my room?
I've got a cup of tea. Here you are. Got that?
No. Hold on a minute.
I'm going to get you
There's
breakfast.
something familiar about him. Oh, come on. Who is it? It'll come back.
Here's your breakfast.
That's better. What's it called? Oh, Fusley. Something. Pathetic. I used to be a chef. I used to make breakfast for hundreds of people every day. Now I can't even help myself to my own
Come on,
breakfast.
let's get you over by the window.
Who is he? Why is he in my room again?
Come
What's he going on at me about? Leave me
for
alone.
goodness sake.
It feels weird. That was scary. I think it's sitting here looking at the garden. It's probably my favourite thing to do. It's so lovely in the summer. It looks a bit flat now. I could do with getting out there with Amy to tidy it up a bit. Oh, it was so fun when I went out there in one welly and one sandal. I thought Amy was going to wet herself laughing. What am I like? That used to scare me so much when things like that happened. Not so much now. Just remember, things will come back properly if I wait and keep calm. I remember the first time it happened. I was outside Jones's in town. I just couldn't find it, even though I'd been stood right outside it. Then, when I did see the name, the letters started falling off. Just fell off, they did. Drifted down. I thought I was going mad. Oh, not mad. Just in nature. Me, of all people. I didn't get it. It's small.
You okay?
Oh, it's Tony. Oh, he was so handsome when we first started dating. I just loved going out on his motorbike. My dad was furious. Have we still got the motorbike?
Motorbike? No.
Can we go to that restaurant at Humphrey again?
Yes,
So
of course.
lovely with Amy and Josh last Sunday.
It's booked as usual.
I do like it there, but it did take me 20 minutes to find my way out of the ladies last time.
Amy came to find you.
Must mean Alison. Alison's always sitting down and having a chat with me. She was here last night. She sat on the end of my bed. We told stories all through the night about the fun we used to have. Oh, it's such a laugh with Alison. Good, clean fun, mind. We don't drink and never swear. What did he say?
It's a bit cold here by the window. Let's get you back to your armchair.
It is a bit cold. Tony really looks after me. He looks so sad sometimes, though. What is it that makes him worry? Hungry. Can I have my slipper? What? No. Can I have my slipper?
These are your slippers.
No, my slipper.
Oh,
For God's sake, my slipper. I'm
it's
hungry.
not time. You.
I want my slipper. I want my slipper. I want my bloody slipper. Now I've upset Tony. Oh, at this rate, I'm never going to get my supper. Oh, supper. Oh, that was my fault, wasn't it? What an idiot. Why do I upset everybody? I'm useless. I love these old pictures. I think that's Alison. I'm not sure who that other girl is, though. I'm feeling a bit better today.
Okay, so what were some of the takeaways from that? What does that, with that bit of insight, what's the first things that come to your mind?
Their brain is always moving from a thing to another thing, is all mixed up in.
Yeah, absolutely. It was very hard to follow threads, wasn't it? Because she kept moving forward and going back, moving forward and going back.
Yeah.
So therefore, when you saw that incident where she was asking for her slippers, what was happening there?
She was
Just getting really frustrated.
Yeah. And why was that? What was she getting frustrated about?
Because she was saying the wrong word.
frightened, or I don't know.
Yeah. So if we think about it, she was looking at those, and in her days, if we go back, let's go back to her generation. Do you think she would have had boots as slippers, or did they look like boots? Did they look like slippers, or did they look like boots?
They look a bit slippers and boots.
Yeah. So they looked a bit, because they looked like grey and a bit neat, a bit higher up. Probably in her day, you know, I remember my nan's slippers. They were definitely flat. They weren't up around the ankles. So she may have been thinking, well, why are you giving me my boots? I've asked for my slippers. So straight away, there's that confusion and that behaviour that's escalating. Not because anyone was doing anything wrong, because it was just that frustration, that sheer frustration of why aren't you understanding what I want? So it gives us that bit of insight, doesn't it? That when we see people with dementia getting frustrated, we need to see it through their eyes. We need to try and see what they're seeing. You know, and if you say to somebody, I've got your slippers, they're here, and they go, they're not my slippers. Do you think there's any level of arguing that you can do to convince them that they are?
No, there's no point to argue.
No, absolutely. So, okay, no, I'm really sorry. I'll try and see if I can find it. And actually, it's that connection, isn't it? And by going away and coming back, and maybe just not mentioning the fact that you've got your slippers, you know, or showing them to them, just by going away, coming back, and oh, let me pop these on your feet to keep your feet warm, rather than even addressing it as a slipper, you can overcome that obstacle, can't you? So you still get the job done, but we're just using distraction and a bit of time technique there. So what we're saying is, people, when we start to see behaviour that challenges in dementia, 9 out of 10 times it's frustration. And if we just took a minute back, we could de-escalate problems quite quickly, couldn't we? And we can avoid all of those problems. So by the end of today, you need to be able to identify these 4 different types of dementia. You should be able to identify them by the signs and symptoms, And hopefully you'll be able to identify the behaviours that go alongside each one. And with the people in which you're looking after, even if you haven't got the diagnosis, you should be able to kind of go, I think it's this type of dementia. Because actually, if we understand the type of dementia, we can provide better care plans and we can provide better ways of working, because each dementia type has a set of behaviours that work alongside them. So Alzheimer's, we're saying between 50 and 75% of people have Alzheimer's. Vascular dementia, 20 to 30%, Lewy body 10 to 25, and frontal lobal, or the front temporal dementia there, 10 to 15. So when we look at the brain, we've got our motor strip. So that's the things that help us move. So if the dementia starts there, we may see the inability to walk properly, or they can't coordinate. Absolutely. Frontal lobal. So we know that the frontal lobal part of us is our emotions. It's our regulatory part. It's the bit that makes us happy or sad. So again, if we've got dementia where you've got quite aggressive and challenging behaviour, because some people with dementia can be quite aggressive and quite challenging, it would probably indicate that it's frontal lobal. And equally, if they're quite tearful and appear to be quite depressed, that's very common and normally triggered from acquired brain injuries or head injuries from the frontal lobal part. So what we know in mental health is those that have head injuries generally have challenging aggressive behaviour, because the emotional regulator bit is obviously damaged. The temporal lobes, the spinal cords, the sensory strips, so again, so sight, smell, sounds, etc. And then obviously the optical lobes, so for sight and stuff. So just having a little bit of an understanding of where in the brain it might be gives you an idea of the type of things that you're going to be seeing. So dementia is progressive. It's irreversible at the moment. And I'm not sure, I don't know if we'll ever get to a point where we can reverse the effects of dementia. We have now got new medication coming out that stops the progression, but only from the stage that they're at. And it's a protein medication that stops the proteins destroying the brain cells. Dementia is caused by the brain cells dying or not working properly. So typical symptoms would be decline in memory, decline in reasoning and communication, changes in behaviour and personality, loss of ability to carry out daily tasks, and eventually, obviously, you end up in the dying stages. So it's quite difficult to get a diagnosis for dementia or the type of dementia. And normally you'd end up going through memory clinics, and it's quite a long, drawn-out process to get those. Common types of dementia, then, we've just talked about it, was the Alzheimer's, vascular, frontotemporal dementia, Lewy body, Korsakoff dementia, that's the alcohol-related one, and the mixed dementia, where you may have more than one particular type. And mixed dementia could be one of the toughest ones to deal with. So if you think about the patients in which you've looked after, the most challenging patients in which you look after are normally mixed dementia, okay? Because actually you've got a bit of everything going on there, and it makes it incredibly challenging. So Alzheimer's disease, obviously it's the degeneration of the brain. It is the most common type. It's the neurons in the outer layer die off first and then to the centre of the brain. It affects the memory and functional skills, so kind of this strip here, and then affects your mood, personality, disorientation in time and space. So Alzheimer's disease is also known as the plaques and tangles. Now it's the plaques in which this new medication works, and the plaques and tangles is basically the proteins of what gets affected. And equally with brushing your teeth, it's the proteins from the gum disease that can go up into the brain and cause these plaques to worsen. So good oral hygiene is really important for people with dementia. It was named after the first person who observed it back in 1907. And again, it was during those proteins, they didn't really understand a lot of it. Obviously, you know, if you think where we are now with neuroscience, we're much further forward. And again, just look at the brain cells and the neurons, and obviously there's a reduction in the chemicals that lead to the information being transmitted effectively. So what we're saying is, in the brain, if you've got a neuron there and there, what tends to happen is information is meant to pass freely, and those plaques build up around, so then the information doesn't transmit from one neuron to another. Okay, so that's roughly what's going on with Alzheimer's disease. It gives you this, I think this gives you a really good idea about what's happening to the brain. So the left-hand side is a healthy brain. The right-hand side is the advanced stages of dementia. So you can see it's shrunk and it's definitely deteriorated. So actually it's quite visually obvious. And again, MRI scans and things like that would pick that up. There are now DNA tests that you can do. So there's lots of tests now that you can do now to see if you're going to be susceptible to Alzheimer's disease. Would you want to know? Would any of you do the test? Would you want to know?
What?
If you were susceptible to Alzheimer's. So we're saying here, you can know up to 10 years before you actually get it.
Yeah, I think I would like to know. Maybe I can do something to stop it.
Yeah, so we can do some advanced decisions, or you could look at that medication to help with the protein, changing lifestyle. And there are definitely things that we can do to help improve the quality of our life. I don't think it would stop it, but equally, it gives you time to put your life into some order, doesn't it? It's those advanced decisions in which you want to make around that. So, obviously, difficult remembering things, poor communication, confusion, disorientation, slow-minded, withdrawal from family and friends, and then problems with decision-making. Okay. So, as Alzheimer's, the progression of Alzheimer's.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part.
So, cheery 3-minute video, but quite a useful video, I think. It explains it really well, doesn't it? Yeah. Is that the first time you've seen that?
Yeah.
Yeah. What did we think of that? Is good, too much, not enough?
It's interesting how the brain has got parts for everything.
Yeah, and that's the stages. So as we see people decline, we normally say it's in 3 stages. And so as you're going around, you can normally call how long somebody has left to live. So actually those first early stages can be there between 1 and 4 years. You know, so you don't really see a lot. You just see a slow decline. What you tend to see is the second stage. They can be in for a couple of years, but that final stage, you know, where everything's starting to disappear, and obviously they have the lack of movement and all of that, then that stage happens quite quick. So normally when you start to see challenging aggressive behavior, we normally call that the second stage, because it's now affecting the mood and the ability to regulate. And therefore we know that we're on a downhill decline from there. But again, just simple little videos like this are really helpful for family members to try and understand what's going on, because actually it can be quite challenging for you to explain it to somebody. But for family members, this is useful for them to see, because I think it's that whole thing, and I'm sure you've all seen this, where family members get upset. Oh, she's forgotten me. You know, why has she forgotten me? You know, I'm not important enough in that person's life. And it's nothing to do with that, is it? It is to do with the disease. Okay. So this was a scientist who was diagnosed with dementia, and he copied some of his memories or did an article.
I am fearful of the day when I put my hands on the keyboard and not know what to do. This is a painful, naked story for me to tell, but everything in my training as a journalist says, shame on you if you don't tell the story. Several years ago, I started experiencing the symptoms, horrific short-term memory loss, not recognizing people I've known all my life, not recognizing places I've known all my life.
Alzheimer's disease is the biggest unmet medical need we have in this country. At 85 years old, 40% of the population are already showing signs of dementia, mostly due to Alzheimer's disease.
After my diagnosis, I named my son power of attorney. So we were out in Coronado for a family reunion. And I said, Brendan, I want to talk to you about my medical situation. He said, I want to talk about it, Dad. So I started reading from the 50 pages of my medical report. And then I got to the diagnosis. He grabbed my 50 pages of medical records. He ripped them into a million pieces and threw them off the balcony. And I watched them fall like snow in the desert. Then he buried his head into my chest and he cried like a little boy. So I grabbed a plastic trash bag and I went down and I picked up the remnants of my medical records. And it was as if I was putting my present life and life to come in a plastic trash bag.
If we want to treat this disease, first we need to understand it at its very roots. If you could go into Greg's brain 15 to 20 years ago, what you would have been seeing is this accumulation of this little protein amyloid that become plaques. And as these accumulate, this amyloid causes the nerve cells in contact with it to make tangles, these twisted filaments of this protein called tau that accumulate inside the nerve cell and choke it from within. And so now the neuron is dying. What we believe is now happening is that as it dies, it spits that tangle out, and that tangle travels to a healthy nerve cell, and starts to kill it by forming tangles. For decades, we argued about which pathology is more important, plaques or tangles. But what we've learned about that process now is that both the amyloid that's accumulating and the dying nerve cells cause a reaction in the brain called neuroinflammation. You have little cells in the brain called microglial cells that normally are trying to clean up all that amyloid as it's made. But if they see too much cell death, they switch from being housekeepers to being soldiers. They cause inflammation. They create free radicals, these little oxygen-based bullets that are killing nerve cells. And then this thing just keeps ramping up like a vicious cycle. More amyloid, more tangles, more inflammation. You can think about Alzheimer's disease as a chronic inflammation in the brain driven by pathologies that are causing chronic stress. And as this disease insidiously moves on, it robs you of yourself. And your loved ones want you there physically, but you're not there internally. It's really hard to imagine any emotional toll that's worse than that.
It's very stressful to lose a thought in a second. 2 days ago, the light went off and I was with my son. I didn't know who he was, where I was, what day it was, and I was in a panic. He calmed me, my son calmed me down because they know. It's okay, Dad. You're here. Today's the date, and this is what you're doing.
I don't believe there's a silver bullet to solving Alzheimer's disease. I think if you want to treat the disease, you have to hit all three pillars of the pathology: amyloid, tangles, and inflammation. You probably need to treat amyloid 10 years before symptoms, knowing someone's in trouble. If you want to slow the disease down, you not only target amyloid, but you stop those tangles from forming and spreading. Third, since there's so much inflammation in the brain throughout this disease, any drug you have that can address neuroinflammation, you don't want to take that early, middle, and late in the disease. Problem is we don't have the drugs yet, but we do have some very promising drugs in trials. To me, thinking like a scientist in order to solve Alzheimer's disease means that you should not be afraid to think big, wildly creative, imaginative, in the privacy of your own mind. But then when you externalize that out to the world, do so with discipline, do so with rigor, because it's your job to treat your world in a way that addresses truth and reality.
I know the denouement of this play, and I don't want to take my family there. And my family is, excuse me, emotional. My family is very important to me, okay? I'm a father. There's that instinct to protect. And how do you protect when you know you're not going to survive? And so I want to make these few years ahead as special as possible. Take care of my family. And then the instinct inside me as a journalist is to tell the story. I'm the canary in the coal mine. This is a grueling, difficult, stay in the moment journey that I'm on. And it's knocking the crap out of me. But if I could see there's some hope in it, then it's worth the journey.
So again, quite hard hitting, but a useful thing to watch. And I think they explain a bit more in detail about those plaques and tangles and the amyloids. But equally, I think what's really important there was the positive message about hope and about that preparing your life. So foreseeing, forearmed, making those advanced decisions. So for us in social care, it's about giving people those opportunities to make those advanced decisions. And it may be the fact that nobody's actually sat down with somebody and said, look, have you thought about what's going to happen? Because the reality is, we never know when those light bulbs are going to turn off, do we? We never know when those stages are going to happen. So early intervention is definitely key there. And I don't know if any of you have seen a movie called Still Alice. If you haven't, I highly recommend it. It's based on a true story of a university lecturer who is a linguistics teacher, and you see her go through the decline of her dementia. And it's really hard hitting. It's a real tearjerker, but it's a really powerful story about advanced decisions and what happens to her. So I highly recommend you watch that. Okay, so that's Alzheimer's disease. So as we understand, it's like a fire in the brain. It spreads and it goes all over, and eventually it obviously stops breathing. So that's your Alzheimer's disease. Vascular dementia is the second one that you need to be aware of. And this is when a supply of blood to the brain gets blocked and then the disease starts. It's the most common type of dementia caused by mini strokes. So the TIAs, mini strokes. And you might see people that kind of jerk a little bit. So those mini TIAs that people have. A lot of the time it can go unnoticed. And what happens in the brain here with vascular dementia, the bleed on the brain, the blood obviously dries out, it congeals, it turns obviously into calcium, and it's a stage called calcification. So again, if you've got blood on the brain, it's going to affect the transmission of information. But what's interesting with vascular dementia is its site. So the bleed is only in one particular area of the brain. So it doesn't necessarily spread like the other dementias. It normally stays where it is. The vascular dementia's onset is gradual or quite dramatic, depending on if it's a slow bleed or it's been quite a large trauma. Regardless of the rate of progression at similar each time, due to the periods, it can move on. So symptoms, I thought I had a video there. So the symptoms with the vascular dementia, if you go back to, I'm missing a slide for some reason. If you go back to the anatomy of the brain, depends on where it is, it tends to just be in that area because that's where the bleed is. So it will affect just the sensory strip or the emotional, if it's at the front, it's mood perception. So with vascular dementia, if we know where the bleed is, we generally know what part of the brain's affected by that. And it's unlikely that it's going to spread. So they don't go through those 3 stages like Alzheimer's disease. It normally just stays quite static. So Lewy bodies.
It happened little by little. First, he would forget things, and then he'd lose track of what he was doing. Lewy body dementia took over the life of the man you're about to meet. The disease is the second most common form of dementia, Alzheimer's being the first. There is no cure, but experts at Mayo Clinic are researching Lewy body disease in hopes of improving the lives of people who struggle with it. In hindsight, though, there were things going on before, but you think, I'm thinking he's 75, I'll be there one day. It's just part of the aging. But the little changes Marjorie Zellers noticed in her husband, Richard, were early signs of Lewy body dementia. Expressions were almost not there anymore. Richard also developed Parkinsonism, which often accompanies a diagnosis of Lewy body dementia. And the stiffness in walking, his gait changed tremendously. Their lives have also changed tremendously. Because he was a boater, tennis player, racquetball player, Richard is not independent anymore. His symptoms are slowly getting worse. 6 months ago, I just kept thinking it's going to go back. I kept wanting it to be like it was. But it's taken a long time to realize that it's not. In a moment of clarity, Richard describes what it's like to slowly lose function.
It's like we wrote all your information on a blackboard and just come in with an eraser and zap through it. And what's left is the problem. And the other ones are gone, and then you're going to come back. You can try and improve on it.
And improving on it is what Dr. Tanis Furman and Dr. Dennis Dixon strive to do.
We tried very hard to detect and diagnose as early as possible because our goal is to try to reduce patient suffering, improve their quality of life. And if we can increase a person's level of functioning to a higher level early on, that's an appropriate goal for us.
Dr. Furman says it's key to make sure the diagnosis is correct. You see, Lewy body disease is often misdiagnosed as Alzheimer's disease, and the two may respond differently to some medications. And because there is no cure, the disease will inevitably progress. Dr. Dixon is researching what Lewy body disease does to the brain.
So the idea is to find molecular underpinnings of the disorders that can be used for biomarkers to diagnose it accurately. And also, if we study the molecular and pathologic underpinnings of the disorder, those might lead to avenues for treatment.
The hope of new treatments to improve the lives of people like Richard Zellers. In addition to making sure the diagnosis is accurate so people can get on proper medications, Dr. Furman says it's also important to help patients and their caregivers get the support they need at home. That can ensure a better quality of life for patients and their loved ones. For Medical Edge, I'm Vivian.
Okay, so with Lewy body's dementia, so what we're seeing there then is where people start to hunch over, the joints start to become a lot stiffer, and you've got that link to Parkinson's disease, so you may have those tremors. And what we know about Parkinson's disease is it's time medicated care plans and making sure that the medication is given before we start doing treatment. So actually, if we're looking after somebody with Lewy body's dementia, we know that there's a lot of stiffness and a lot of joint and that off balance. So equally, and what she's saying there is it's that misdiagnosis. So if they're being labelled as Alzheimer's disease and that's not what it is, then actually the medication used for Lewy body to help loosen the body, soften those muscles, stop that stiffness, stop people kind of hunching forward and falling over, they're not getting the right medication. So for you as caregivers, you as nurses and assistant practitioners, spotting those signs of maybe, look, maybe this isn't Alzheimer's, maybe this is Lewy body, because they're getting stiffer and stiffer, and you can start to see that the tremors and the shakes. And that's a really good time for you to kind of go, look, I think this person's been misdiagnosed. And what he was talking about in the biomarkers, when they obviously take the sample of blood, they'll be able to tell in the protein levels whether or not it's now Lewy body. So the test is now a lot more accurate than it was. But the reality is, it's that misdiagnosis. And we know in mental health, 50% of diagnoses are normally misdiagnosed. So it's important that if we are seeing signs of misdiagnosis, that you're able to pick up on that and do something with it.
Williams.
So again, progressions with Lewy bodies, it really very much is to do with the coordination. So people that are at risks of falls, can't coordinate the hand-to-mouth movements, and really are those slunts, hunched up people. They're generally, that's generally where what we're seeing. And they're the ones in the morning when you get them up and they're quite stiff, when you try to move their arms and it feels like you're fighting them. So again, it's worthwhile you going back to reading people's care plans and going, is this Alzheimer's or is this something else? Obviously, it's quite a complex condition. We've already said it's about 10 to 50%. It's linked to Parkinson's disease. So if we understand the symptoms of Parkinson's disease, problems with hallucinations. So again, you see a lot of the air grabbing, and again, problems with sleep. So people with Lewy bodies might be your night walkers, the ones at night that don't tend to sleep, because obviously they have trouble sleeping. So again, just having a little bit of awareness around that, trying to get those symptoms right would be really helpful. So we've already talked about falling, hallucination, stiffness, and obviously those Parkinson's symptoms. So I think for you as assistant practitioners, this one's quite easy to spot, I think. You'll see this quite frequently. Management then, medications, physiotherapy and cognitive stimulation therapy. So light, sounds and sensory stuff is really useful for Lewy bodies. Front temporal, so people under the age of 65 with front temporal damage is the most diagnosed dementia, less common in over the 65 brackets. Again, caused by cells and pathways of the frontal lobe being damaged. Looking again at the proteins and the communication between the two. Normally known as, you might have heard of Pick's disease. I don't know if you've heard of Pick's disease. Have you heard of that one? No. Okay. So Pick's disease is, if you think, as I was saying, frontal lobal is where your emotional regulator starts. So people with Pick's disease are normally your aggressive people with dementia. They're the ones that are really challenging. You know, the ones that bite, scratch, punch. So if you've got somebody who is quite challenging, it is normally because they've got front lobal dementia. So the emotional regulator bit of the front is damaged, and that's why you're getting all of this aggression. So it doesn't matter how much care planning you do, it doesn't matter how much safety stuff you're doing, you are still going to get that behavior, because that's just the way now the brain is wired. So it is useful to know when we're looking at care planning, if it's Alzheimer's, you've got a chance of managing that behavior because you can bring people down, you can use distraction, there's those calming techniques. With Lewy bodies, not necessarily, you don't really get aggressive behavioral Lewy bodies because they're just too stiff, they haven't got that movement to fight out. The frontal lobal, the Pick's one, because it's more common in the working age as well, because again, head injuries, etc., they're generally quite quick at those punches. So knowing this, it's quite important. Equally, with Pick's disease, what you tend to see is over-sexualized behavior. So if you've got your older people that are slightly more sexually active, you know, they like to squeeze your bum, touch you, normally associated with Pick's disease. And the other dementias, they don't normally have that over-sexualized behavior. So the ones that are quite happy to strip and run around naked, normally associated with Pick's. So again, just having that bit of awareness gives you an idea of the treatment plans and different strategies, because actually it's all about the behavior, trying to manage that well. And again, just gives you an idea there of the brain. So here, as I've just said, signs and symptoms there then, inappropriate social behavior, like sweet foods, signs of distress, anxiety, seeing things, could be that obsessive behavior. So what you might see a lot of the time is them touching or wiping something. Yeah, so you might see that quite a lot. Changes in personality, the apathy, so just no sympathy or no willingness to do anything. Repetitive behaviors, and obviously problems in solving problems and stuff. So we'll just got a video here on this one.
Dementia is a problem of the elderly, right? Generally, that's true, but there is one form of the disease that can strike people when they are very young, in their 20s or even their teens. It's called frontotemporal dementia, or FTD, and while rare, it devastates lives by rapidly turning young, vital people into those who need constant care. More from Mayo Clinic. And we were seeing our son disappear before our eyes, little bit by little bit. Sue and Bill Bishop are watching a disease called frontotemporal dementia, or FTD, consume their son Brad. The brain disorder with no cure is changing him from a caring young man with a bright future into a person whose behavior is erratic, childlike, and at times inappropriate.
Who is it? Who is it?
I have to see who's calling.
Who is it?
It's Brad's body. Of course, even that's different. Brad's first symptoms were subtle personality changes. He'd forget to return phone calls and emails. He'd act childlike in public, and he grew self-centered, a trait his parents say was completely out of character. And as the disease progressed, symptoms got much worse. Brad became agitated around people, and he couldn't control the urge to eat. So we literally had to put locks around the fridge and freezer. For more than a year, doctors did not know why this was happening. when we were told that there is something rapidly, progressively attacking your son's brain, and we don't know what it is. I lost it.
Just going to check your reflexes here.
Then the bishops met Mayo Clinic Dr. Brad Beauvais, an FTD specialist.
That's when we started on our journey. It was a long, painful journey, but at least now we know what Brad has.
But for the families, it's frankly a nightmare.
Dr. Beauvais says FTD affects the frontal and temporal lobes of the brain, which control things like judgment, language, and social behaviors. Research suggests that FTD is the result of malfunctioning proteins that cause your brain cells to die prematurely. This causes brain tissue to shrink. Medications help manage some symptoms of FTD, but at this point, nothing can stop it.
We want him safe. We want him happy.
As happy as we can make him, comfortable.
And the bishops want others to know about FTD, so families can intervene early and get their loved ones the supportive care they need as they live with this devastating disease. Again, there's no cure for FTD. Some people live with it for many years. Others lose the battle more quickly. Dr. Beauvais says that there is hope for patients with FTD. As researchers learn more about how it affects the brain, they'll be able to tailor medications to hopefully slow the rate of progression, stop progression altogether, or even prevent it. For Medical Edge, I'm Vivian Williams.
So again, hopefully, you know, there's going to be people that you've now probably can link with this that you've looked after in the past. And again, just knowing the type of dementia gives you a much better idea about the treatment, the care plan, and the things to do around them. And equally, if you go back to positive risk taking and go back to the assessments in which we were doing, this is where you could start saying, look, is this 2-to-1 care? Is this is always going to need this? Because actually, it's that behaviour associated with that condition. So having that insight is really useful. And having that insight, you can warn other people about it. And I think the hardest part around it is the over-sexualised behaviour, the selfishness, or the lack of insight, or the aggression, because none of those are nice traits. It can be quite devastating for the family to go through that. And as carers, it can be quite hard, you know, well, why are you touching me there? Or why are you smacking my bum there? Nobody else does that. Why are you doing it? They've got dementia, you've got dementia. Why are you doing it and they don't? So understanding people's behaviours gives you, the caregiver, a lot more insight and awareness and sympathy to that condition, because actually you now know it's part of that particular dementia group. It's that it is just associated with that part. So looking at those different types of dementias, do you now think that you could go back to your homes and identify people with different conditions?
Yeah.
Yeah, and that's really what this is about. You know, yes, you're not going to be experts overnight, but I think Pick's disease is very particularly easy to spot. You know, it's very easy to spot this one because it's working age, it's functional people. You've just got this behaviour and this decline that you see, where Louis' body very much is that cramped up, and Alzheimer's is just that kind of, you don't see all of this with it. Alzheimer's is that just progressive, more inward, more mental health, more kind of the signs of depression, etc. So hopefully it gives you now thought as you work with people with dementia. Frontal lobal, obviously all about routine, because their short-term memory is reasonably okay to begin with, because it hasn't hit the hippocampus in the back where the memory is, it's all at the frontal part. Okay, so alcohol-related or substance, Korsakoff dementia, alcohol-related dementia, affects people in their 40s to their 50s, 10% caused by young onset or diagnosed. What other substances do you think that we are now starting to see because of substances causing dementia? I don't know if I've put that question correctly, whether that was easy to understand. So think about not just alcohol, what other substances are we now seeing causing early onset dementia in people?
With drugs.
Yeah, those illegal highs, or what used to be called the legal highs. So things like poppers, spice, black mamba, all those synthetic drugs. And the problem with all those synthetic drugs, they're not quality checked. We don't know what's being mixed in them. And what we've seen in younger people is a massive increase of early onset substance-related dementia, because these chemicals that people are taking are just destroying brain cells. And obviously, once we've destroyed those brain cells, it's a problem. And that's, you know, and we see that a lot, especially with those legal highs. I think with spice has been the biggest.
Can I ask you something?
Yeah.
Is substances from the vape dangerous as well? I'm not using, but I'm just asking in general.
The answer is, I don't know if there's been any studies for dementia. We know that vaping is bad for respiratory conditions because your lungs are meant to be dry, and if you vape, you're taking in moisture. And we know our lungs are meant to be dry. So actually, I think what we're going to see in the next 5-10 years is a massive increase, and we're going to move on to that this afternoon for COPD and chest infections. We're going to see lots of respiratory problems because of vaping. So it's going to be opposite to the drive. But I don't know if there's any evidence yet on it affecting dementia. Definitely related to psychosis and other mental health conditions, but not dementia. Okay, so obviously we're looking at toxins affecting the nervous cells, and basically depending on which part of the brain gets affected, you get that behavioural type. So if it's movement or whatever, you've got those. So we're looking at symptoms there, again, could be gradual, normally working age, problems with memory, problems with coordination and linking things up, generally is the problem there. And again, can be caused by a B1 deficiency. So again, look at your vitamins there. So alcohol-related brain damage tends to be more common in people in their 40s and 50s. Why do we think it's more common for people in their 40s and 50s? What happens to us in our 40s and 50s?
I think our brain is not working the same.
This is like a bit more obvious socially. What happens to us normally when we hit 40 to 50?
I don't know, it's saying something with like the hormones are more.
Okay, so first of all, we've got hormones. So with women, we've got hormones. With men, we've got testosterone. So if male testosterone starts to dip down, we get the male midlife crisis. We get tattoos, we get a motorbike, and we try to be young again. Doesn't work. Always ends up as a car crash. With women, we go through the HRT or hormone replacements. So that can cause a problem. Equally, what happens in our 40s and 50s, it's normally when our children are grown up and adults get their lives back. Mm. Meaning we can go out, we can party. The problem is we then start to do it to excess. So we start to make all the wrong choices again between our 40s and 50s that we made in our 20s because it's that freedom. So what we tend to find is between 40s and 50s, there is a lot of problems in mental health, primarily because people are getting their lives back, primarily because we've got testosterone or HRT going on, or hormones. And equally, what we tend to find is people are more acceptance of risk. So we tend to start to live for them now rather than the long term.
They said life begins at 40s.
Exactly. So, well, and I'm probably because we live in 10 years longer now, it'll be life begins at 50. So it is a true thing. We do tend to see, and the problem is our bodies don't process the same as what they did when we were in our younger days. You know, when we were in our younger days, We could all have those party nights. We could all have those long days, but we'd still get up and go to work the next day. I'm sure you have all felt, and I'm not judging anyone on their ages on here, but if you've had a few drinks the night before, the next day tends to be a little bit harder. When you're in your younger days, you could do it. The reality is we process differently. And obviously, if our kidneys aren't processing the alcohol properly, the toxins are still in the body, and those toxins are going to go somewhere. So again, obviously puts you more at risk of alcohol-related dementia. And equally, if it's early onset, it becomes a bit more rapid as well. However, symptoms for substance misuse, deterioration of ability to plan, decision making, and sequencing becomes a problem. Change in personality, because your personality and your mood changes. Reduction in impulse and emotional control, and problems with attention and memory. And this is probably the hardest one. Mixed dementia is where you would have Alzheimer's and then vascular or one of the other ones. So you have then two lots of problems going on. So you've already got the 3 stages that we go through, and then you've got the other problems in which either vascular might be bringing, so you've got the symptoms of Parkinson's disease and the shaking or tremors, or you've got the PICs, the over-sexualized behavior and the touching. And it just becomes really difficult to manage people that have mixed dementia. So again, understanding that would mean the people with mixed dementia, you're going to probably do a lot more with them in their days. So you try to keep them busy from morning to night and just keep their day fulfilled with meaningful activities. Because if you don't, it's going to be behavior after behavior after behavior. And it becomes really difficult to manage people with mixed dementia. And again, it's that behavior that goes alongside mixed dementia. So understanding them looks at treatment as well. A couple of the other ones then that are related into the family. So Huntington's disease and Parkinson's disease. So do we all know what Huntington's disease is? No. So Huntington's disease is the muscular one where your brain is still okay, or your memory is still okay, but the rest of the body just deteriorates. So you can't then move, you almost get locked in, you've got no facial expressions, you can't talk, you're just looking. And it's really sad. It's a terrible, terrible, out of all of them, it's the one you wouldn't want the most. And so if you've never seen Huntington's disease, Google it and have a, you know, there's lots of videos out there for you just to watch. But it is one of the more hardest ones to work with. And then Parkinson's disease, we know with Parkinson's disease, it's all about medication, the tremors, the off the balance, and eventually that ends up in loss of life. So supporting to live with dementia, we go back to our enablement stuff. It's all about promoting independence, all about making those reasonable adjustments, all about looking at equipment adaptation and trying to see the world through their eyes for less frustration. So when we do that, we need to think about the world in which they're in. Does it reflect the world that they've got now? So the Mental Health Act and dementia, if you have a diagnosis of dementia, you're automatically assumed to be somebody who lacks capacity because of a cognitive impairment. However, you still can make decisions around your day-to-day rights and choices. It's just assumed that you can't make those advanced decisions. Therefore, LPSs need to be applied. So liberty protection safeguards need to be applied. And that's for somebody who lacks capacity and to accommodate their care and treatment. And this is about those advanced decisions. Okay, so looking at how you want to be treated, what does your end of life look like, and what are your typical days. And equally, we go back to what we were talking about a couple of weeks ago about managing those behaviours of people. So positive behaviour support plans. You know, we know if we're dealing with PICs or mixed dementia, regardless on admission, we need a positive behaviour support plan because we know we're going to get behaviour that challenges. It's a given, it's a symptom of the condition. So we don't need to wait for it to happen. We can be looking at those strategies on how are we going to deal with this person if they refuse to go to the toilet? How are we going to deal with this person if they refuse to have personal care? you know, and this is the stuff that we should be doing automatically. So mixed and PICS, definitely. Obviously, your likes of Alzheimer's, if you're in early stages, they're still able to reflect and think about the things that they want. Okay. Restraints and laws, a measure of control to keep somebody under control. So again, looking at restraints, so this goes back to our positive behavior training. We know that a restraint is direct or indirect, and it's the indirect restraints that we need to be thinking of when we're working with dementia. So for example, can I leave you in the bathroom on your own? Can you go outside in the garden on your own, or are you at risks of falls or injury to others? Now, the reality is, if you've got mixed dementia or PICS dementia, you probably need to be in eyesight, because you are going to be at risk of hitting somebody because they're unable to control their emotional regulators. So if somebody does something to offend them or upset them, you're going to have behavior that challenges, aren't you? Is that then a risk that you need to be addressing early on in your care planning? Can I let you outside on your own, or should you always be under staff supervision? Equally, around the positive behaviour support, we've already looked at restraint and risk reduction, so we're not going to go into this, but we know that there's those stages from the training that you've already done. Identify the triggers, de-escalate, look at different approaches, walk away, or stage 3, it's going to result in some form of restraint, because they are our 3 stages, aren't they? We know that. But equally, we would have planned that on admission, because we know mixed and PICS, we're going to get those behaviours. Don't need to cover that, you've already done that training. We've already looked at positive behaviour support plans, so we can skip that part, can't we? And we've looked at those. Right, so decision making. How would you feel if somebody started to make decisions for you? How would you feel if I started to say, right, here's a cup of tea, or, you know, there's your orange juice? How would you feel?
It's frustrated, isn't it?
Yeah, you're going to feel frustrated. So that's one that you might feel. What else might you feel?
Someone is in control of you.
Yeah.
Yeah. So it's that control aspect, isn't it? Are you controlling me, or am I losing control of my life? So all of those is quite a lot to take on board, isn't it? And for you, I'm going to make this assumption that you're compassionate about this, you know, because you work in the industry, you're aware. But you must see it when new members of staff come in and they're trying to do what they think is kind, but they just don't understand, by not offering that choice, by not doing that little thing, how much that actually would impact you. And it's about us as being those teachers for new staff, to explain that importance of control, you know, and how you would feel. And actually, we know people with dementia go through depression and anxiety, and all of that goes untreated because it's masked under the dementia umbrella, isn't it? I mean, if you think about your medication for your patients, those that are dementia, are any of them on any antidepressants of any type? Probably not. It's really hard. And the reality is, if you had dementia, you would probably be depressed, right? You are going to have feelings of low mood. So just because somebody has dementia does not mean that they're not going to have any underlying mental health conditions. And we need to be a bit more mindful of that when we're planning people's care. So communication, I liked this bit. So we communicate for reason, we communicate our feelings, we talk about what we want and why we need it. And I'm going to go back to what I keep saying, Sharon and Weaver, about the sender and receiver. It's one of your theories. It's in your communication module when you move down, much further down. But we know when we communicate or when we do something, there is a meaning behind everything we say or do. Okay, so we do 7% through what we say, 38% through our tone, and we do 55% through body language. So the reality is, even though they can't communicate with us, that's only 7%, of what's going on. The rest I can get through tone and through body language, can't I? So if I don't understand somebody, even if English is a second language, I should still be able to work out what people's needs are just through the body language. So we all have, well, there's hidden meanings behind everything. So if I was to say to you, if I was to say to you, I want to go home, what am I actually saying? I want to go home. What's the meaning behind that?
Longingness.
Okay, yeah, that's one. I want to go home.
Wants to do with his family, her family.
So
You want to be safe.
yeah, exactly. We associate home with a place of safety, don't we? So if you've got somebody with dementia who can't communicate and they go, I want to go home, or home, 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 what they're actually saying to you is they're afraid, they're scared, they just want to go to a place of safety. So with them saying that, your response should be, why don't I take you to a quiet room? Let's just get you a bit more comfortable. Let's try and work with that anxiety or worry. If I was to say, mother, mum, I want my mummy, mum, what am I calling for?
Love and protection.
Because we associate mums with that love and protection, don't we? So the meaning behind that is, I'm feeling scared. So as carers, all we need to do at that point is take their hands and just stroke them, you know, show them that love. And even though their world is confused, they may not be connecting who you are, but they're going to get the message across. If I go, I want my children, where are my children? What am I saying?
Family.
Yeah, I miss them. I miss that connection. Father, dad, where are you, dad?
Security.
Because the men are seen to be the safety, the security. So again, you may feel threatened. And then work. I need to go to work because I can't let go of that work thing. What are they saying?
I think you miss the old times that you've been in there. And
Yeah, I need to be busy. I want to do something. I'm bored, you know. So when we look at the meanings, home means I'm worried about something. I'm alone. I'm confused. I don't feel safe or secure. I've got a loss of identity. So it's down to us to take what they're saying and interpret that meaning back into a sentence, because they can only give us one word because their sentencing's gone. Mother, if they're calling out for their mother, they feel lost, alone. They need that to be loved, a feeling to be worth, or a feeling to be needed. Children, purpose, they need to be depended upon, and again, that feeling of love. Father, I need to be protected, or I need to be belonging somewhere. So again, they may just feel unsafe. Our job is to try and make somebody feel safe. And then work, I need a purpose. I need to be doing something. And when you think about your services, we need to be thinking about all of the stuff that people could be doing. You know, there is many a times that I've given dusting cloths to my ladies and said, right, okay, look, here's my duster, off you go, you clean that. And all right, it may take them the whole morning, but they love doing it because it just gives them a sense of purpose again, doesn't it? So equally, we have a problem with communication around mother tongue, lots of multicultural differences. And the problem is when people revert back to their first languages, that could be a problem. But we've seen that actually we can cross those boundaries just by body language and tone. So other communication difficulties we have is the noise levels, people around us, hearing aids, activities, lights, lounges. So when we are talking to people with dementia, we just need to be mindful about what's going on around us and the environment in which we're talking to. So, and we'll do this and then we'll have a 10-minute break. So hypoglycemia, so this is about the phenomenon of muddling things up. So this activity just gives you a bit of an insight to what it's like to see reading through the eyes of somebody with dementia. And you know, when people go, oh, it's the default answer, I think, in all your MVQs, people go, oh, how do you communicate with somebody? And you go, oh, I can put it in writing. Okay, which works to a degree if they can read. But if they can't, then it's a bit of a problem. So what does this say? Does anybody want to give it a go?
According to research at Cambridge University, it doesn't matter in what order the letters in a word are. The only improminating thing is that the first and last letter be at the right place. The rest can be total mess, and you can still read it without problem. This is because the human mind does not read every letter by itself, but the word as a whole.
Perfect, well done. So I think that's amazing, don't you? That our brain actually can work that out straight away, no problem.
Mm.
Yeah. What about this one? So it gets a bit more complicated now.
Doctor was admitted of the Tangne
Teenage.
Don't know.
Yeah, it's a bit harder, isn't it? It gets a bit harder. Okay, so it says a doctor was admitted the manslaughter of a teenage cancer patient who died in hospital after a drug blunder. Okay, so again, if that's how your brain's seeing it, you can just see, I have to work really hard to read this and understand it. Okay, and then what starts to happen? So when you're reading this, what are you thinking to yourself? What do you feel when you're reading that? Do you feel frustrated?
Yeah.
Yeah. So again, this is a skill that we can all do, but now all of a sudden I can't do it. Why can't I do it? Or you start to feel stupid. Why do I feel stupid? Why can't I do this? So again, we then understand that actually asking someone to read something could be a trigger for aggressive or challenging behavior. So this one's probably the hardest one. Anyone want to have a go at this one?
In the vaccination, our lovely realm green finality promulgated form schemic we use in fabrics and popular payrolls as dresses.
Very good, very good. So in the Victorian era, a lovely green, emerald green, particularly formulated from the, with the purpose of floral headdresses.
Fabric and popular floral headdresses.
Yeah. So again, it just gives you that sense of, I should be able to do this. So just before we stop for a break, how did you feel by doing that activity?
You're very pressure.
Okay. And did you feel vulnerable though? Did it make you feel a bit uneasy to do it? Because there's this assumption, isn't there, that we, if we say, look, can you read this? We just assume people can. Because actually people don't want to admit if they can't read something. So just because we put it in writing, and this works really well for staff that we're teaching, let's face it, a lot of people that work in social care, English is a second language, or there is some disability there. So they may be dyslexic, or they may just find learning a lot harder. And when we do those notes, we go, but I wrote it in the notes. I wrote it in the diary. The problem with the Shannon and Weaver model is the sender and the receiver. You have to, as the person giving communication, you have to be sure that the person that's reading it can understand it. And that's the problem. When we have all of these problems at work and all of these communication breakdowns, you can have as many memos as you like, but it doesn't mean that people are reading them, or if they are reading them, that they can understand them. So as a leader, you need to be thinking about that activity. And when I ask somebody to do something, what is the way around this? How can I do this? Verbal, written, and that reflection. And whenever I ask somebody to do something, as annoying as it is at work, I always say to them, what did I just ask you to do? and I get them to tell me back, because it's the only way that I know that they understood the instruction. And we just don't do that, do we? So anybody, when I ask somebody to do something, I always repeat it. So you'll always hear me say something twice if it's an important thing. And I always get you to repeat back the instruction, because only then do I know that you've got it. Other than that, we go around assuming people have understood the intent of something that's written. And that frustration that happens behind it can be really painful. Anyway, let's stop for 10 minutes or 15 minutes.
Yeah, 15 minutes.
15 minutes, and back for 5 to 12, if that's okay.
Yeah, thank you.
Lovely.
Set alarm.
Your alarm is set for 11:55.
Okay, so communicating people with dementia, we've gone around this now. We've looked at some of the meanings. We've looked at kind of understanding what's going on in the brain, where it jumbles things up. So this little video gives you an idea about different techniques on supporting people.
We'll now show you 3 example conversations. 2 use the message strategies and 1 doesn't. After each example, there'll be a chance to pause and reflect on what worked and what didn't. Then we'll review these points with our expert, Professor Helen Chenery. In this clip, see how well care assistant Debbie does in maximising Stanley's attention, expression and body language, supporting his conversation, assisting with visual aids, getting his message, and encouraging and engaging Stanley in conversation. When you were in Geelong, you supported the Geelong Football Club, didn't you?
Yeah.
They're your favourite team?
Yeah. I was playing for them for 2 seasons.
Oh, did you? So you played for Geelong? Okay.
And they had a city team
Yeah.
and a country team.
Okay.
And I was playing for the country.
Ah. Yeah.
And the city doesn't like the country.
Oh, the country team.
Yeah. And they hurt my leg.
Well, did they? Did you beat them? Did you beat them?
Yeah.
Well, that's the main thing, isn't it?
You may have noticed that Debbie set the conversation up well by maximising Stanley's attention. She was sitting at his eye level and maintained eye contact throughout. She came across as relaxed and was showing her interest through her voice and gestures. She used the football scarf as a visual aid to help orient Stanley to the topic.
When you were in Geelong, you supported the Geelong Football Club, didn't you?
Yeah.
Debbie chose a topic that was familiar to Stanley and showed knowledge of his interests.
They're your favourite team?
She also accepted his contributions as meaningful, even though he said something rather unexpected.
I was playing for them for 2 seasons.
Oh, did you? So you played for Geelong? Okay.
Debbie encouraged him to continue by giving him extra time,
saying mm-hmm, and reflecting what he said back to him.
And they had a city team and a country team.
Okay.
And I was playing for the country.
Yeah.
And the city doesn't like the country.
Oh, the country team. She supported his understanding by repeating, "Did you beat them?" when at first he didn't seem to understand. Did you beat them? Did you beat them?
Yeah.
Well, that's the main thing, isn't it? Overall, in this conversation, Debbie was a supportive listener and helped Stanley to make the most of his communication.
In the following clip, see how well the care assistant Katrina does in terms of maximising attention, supporting the conversation, keeping it simple, and getting Stanley's message.
What did you have for breakfast? Do you recall?
I don't know.
You don't remember? Did you enjoy your breakfast?
Strangely enough, I did.
No. What did you have for breakfast then?
I don't know.
You don't know? So, did you enjoy your breakfast?
I don't know. I had it.
No. You told me you were sick, darling. Do you want to see a doctor?
No. I'm okay. Just a bit off, so.
Oh. How come you're sick, darling? What do you want me to do? Do you want me to call the doctor?
No, I've
Do you want to see the doctor?
no. Just cranky.
Cranky? Why? What do you want me to do then?
Oh, no, not this. Not today.
Although Katrina had good intentions, there were things she could have handled differently to make the most of the conversation and to avoid upsetting Stanley. Katrina moved around while she was speaking to Stanley. This can be distracting and makes it difficult for the person to pay attention. Katrina asked a type of question that can be very difficult for a person with dementia about what he had eaten earlier that day. She also added an extra question, "Do you recall?" making it difficult for him to hold the main question in mind.
What did you have for breakfast? Do you recall?
Instead of helping Stanley out by saying something like, "I think you usually have toast," she drew attention to his memory problem.
You don't know?
She did then try to keep the conversation going by asking an easier question on the same topic, and Stanley gave a clear answer. However, instead of responding to that, she just repeated the earlier question that had given trouble.
Did you enjoy your breakfast?
Strangely enough, I did.
No. What did you have for breakfast then?
I don't know.
Again, Katrina drew attention to Stanley's inability to answer and seemed not to have listened to what he had already said about enjoying breakfast, because she asked the same thing again.
You don't know? So, did you enjoy your breakfast?
The way Katrina called Stanley darling could be interpreted as over-familiar or as talking down to him.
No. You told me you were sick, darling. Do you want to see a doctor?
Katrina didn't keep things simple in the way she asked questions. She asked a series of questions with no time in between for Stanley to answer. And then, when he finally got a chance to answer, she interrupted him, once again repeating a question he had already answered.
Oh. How come you're sick, darling? What do you want me to do? Do you want me to call the doctor?
No, I've
Do you want to see the doctor?
Katrina didn't pay attention to Stanley's verbal and non-verbal communication,
so failed to get the message that he had had enough of this conversation.
No. Just cranky.
Cranky? Why? What do you want me to do then?
Oh, no, not this. Not today.
So overall, this interaction seemed to leave Stanley feeling frustrated at not being understood.
In the next clip, see how Debbie does in her conversation with Ivy, who is in the more severe stages of dementia. Think in terms of expression and body language, support the conversation, get their message, and encourage and engage in communication.
You've been here a nice long time, Ivy? About that long?
About that long?
Roughly. Have you had some lunch? Was it good? Yeah? Have your family been in to see you lately? Yeah? My daughter. Your daughter Susie. She came in. Yeah. Was that good?
Debbie did well to facilitate an enjoyable interaction with Ivy, despite the severity of Ivy's dementia and her communication difficulties. Debbie appeared relaxed and interested throughout. She gave Ivy plenty of time to respond. She accepted Ivy's vague response because the important thing was the interaction itself rather than the content. She also reflected Ivy's words back to encourage her to continue.
You've been here a nice long time, Ivy? About that long?
About that long?
Roughly.
Debbie signalled the change of topic by leaving a pause and clearly mentioning lunch.
Have you had some lunch?
She took note of Ivy's non-verbal responses in order to get a message.
Was it good? Yeah?
Debbie encouraged Ivy to contribute more information by giving minimal responses like, yeah, and being able to mention Ivy's daughter's name would have helped with rapport.
Have your family been in to see you lately? Yeah? My daughter. Your daughter Susie. She came in. Yeah.
Although Ivy didn't say much, Debbie engaged with her and provided a positive communication experience.
This brings us to the end of our message presentation. We hope that the message strategies will help you to help people with dementia make the most of their communication.
There we go. So communication strategy there for managing people's conversations in dementia care. And I think that's a really nice acronym there to kind of take back and to use within your place of work. So when we look at our care planning processes and
I can't hear you very loud.
oh, can you not hear me?
Not very loud.
Not very loud. Oh, I don't know what's happened. Let's see if I can turn my volume up. That's like, can you hear me now? Yeah, is that better? No? Oh. Give me 1 second, everyone. Try that. Okay, can you hear me now?
Better.
Okay, so what we saw there was a strategy for managing communication in dementia care, so the message strategy. And actually, it's a really useful thing to write on a care plan for people to understand how to communicate with that person. Because I always find it difficult to write useful strategies to help people communicate. So hopefully that's given you an idea on how to work with people with communication issues. So moving on now to the senses. So what's all of our senses?
Eyes, ears, nose, throat.
Perfect. Yeah, wonderful. All on screen. So sight problems, people with dementia. As we age, we need 3 times more light to help us see things. So the lighting in our homes can be quite difficult for us to see, especially if we're sitting in quiet rooms and stuff. And again, if we would do this face to face, and when I come out to see you all, I'm going to bring you these glasses, so you get to pop them on, and basically you'll get to see what it's like to go through different types of eyesight. So you'll see what it's like to have low level, you'll see what it's like to have muscular degeneration, you'll try the tunnel vision ones, and you'll have the diabetic glasses, so you'll put these on. But what I've also got is these headsets, and there's a VR thing for you to have a play. So when I come out to see you, we're going to have a very busy day when I come out to see you, but you'll have these headsets on, and you'll just see what it's like to be in the full world of dementia. Okay. Obviously, if we're supporting people with visual impairments, we need to be thinking about those other strategies around. So really clear communication, lots of reassurance, putting them at ease, and we need to be thinking about the environment. We know that people with dementia find it difficult to see certain colours on the low end of the spectrum. So that's why dementia-friendly homes should be quite bright in colours, and hopefully your homes have those nice colours in which they can see. The reality is, if we've got one colour going through our home, it makes it difficult, doesn't it? I mean, I know when I've been into a hotel and all the rooms look the same and you're trying to find your way around into which room's yours, it can be really disorientated. And I saw something on the news the other day that a company, a care home, had taken photographs of people's first doors, and they've put the stickers on their bedroom doors, so it looks like their bedroom door is their front door to their house. And it's how you've done that as well.
Personalized and a name on it.
Lovely. And I've seen lots of great stuff in dementia homes now. So you've got memory boxes outside with their personal things, pictures of when they were younger, or their signs. So again, lots of positive things are happening in dementia homes. So dementia-friendly colours is obviously what we were just talking about there, just making sure that people can see what's in each room, and that they're aware. So hopefully in your services, you've got pictures of the bathroom on the bathroom door and toilets, etc. Mirrors, are they a good thing or a bad thing?
Bad.
Yeah, so in here, what does it make it look like?
You need to go through the door.
Like a corridor, doesn't it? So again, we need to be thinking about our environments. We're not going to do those case studies. So technology is a problem for people with dementia. It's not just for people with dementia, it's a problem for all of us, because it just keeps changing. And as each phone comes out, it gets smarter and more difficult to use. And the more we get afraid of using them because we get stuck to what we like. And that's kind of how it works with dementia as well. So modern technology to us can cause us anxieties. To people obviously with dementia, it's a whole, you know, it's just one step too far, isn't it? But it's about recognizing what they had back in their day, and looking at the equipment and maintaining the furnishings and stuff, just so it's familiar. And equally who we are, about our identity. So knowing a bit about who they are, having those personalization bits. And I'm sure in all your homes now, you're personalizing rooms and having photos encouraging those. Who am I and life stories? We tend to now do that a lot in dementia care, so we can talk about their earlier stages, because that's where they're going back to on that bookcase as memories are dropping. The ones furthest back are the ones that they're remembering. So knowing things like where they went to school, did they go to university, when they got married, it allows you those conversation points, doesn't it, to go on, which is obviously useful. Personal history can be triggered through photos, memories, certificates, uniforms and objects, and that's why we talk about those memory boxes and having those things for them. And life story work is really important. And it's important because it explains a lot of behaviour. So there was an incident with a lady who used to sit there and she used to tap on the table. After doing some work, we'd found out that she was a secretary in the war and she was just tapping away. And for her, that behaviour was her typing. So it made sense once we understood her life story. So when we see people doing things, rather than thinking that's an odd behaviour, can we link it back to probably what they were doing when they were younger? And obviously, it's all about self-esteem, having those talking points, and giving people purpose. What we know with dementia care is keeping people busy gives them a sense of purpose, and that's what we need to be doing. And when CQC come out, they're looking for purposeful activities, meaningful activities that are relevant to that individual. The activity basically is this: does it give you a reason to get up in the morning? You know, and when we get up, is my life worth getting up for in the morning? And that's the environment of care in which we need to be moving things to. We've already done person-centered care planning, so I'm not going to go over that. But we know it's not just a static thing. So ethics in care, I don't know if I've done ethics with you yet. Have I done ethics? Don't think I have. Okay, so ethics in care relate to everything that we do. So it's an underlying principle. We've got our core principles of ethics, our theories, our codes of practice, and how we impact on others. And I just want to throw a question out there to you all now, and we'll see whether you change your answer after we've done this section. So imagine you've got your 92-year-old man, let's call him Bob, and Bob's family have said to you, please don't tell Bob he's dying. We just don't think he needs to know. Bob asks you and he says, am I dying? You've obviously known he's terminal. You've been told by he's terminal. Do you tell him or do you not tell him?
We need to know if he's got capacity or not.
But he has capacity.
So we have to tell him, yeah.
Okay, so you would tell him?
Yeah.
Okay, even though the family said, please don't?
Yes, because it's his life, he has to know, and he has to take the decision, not family, yeah.
Okay, do we agree or disagree with that?
We need to be honest, isn't it?
Yeah, telling the truth.
Yeah, malipas, kind of.
Anybody else got any different theory on that?
So we was talking about as nurses, we are not telling them, it's not to us to tell them. That was in the before, I don't know, another group of doctors, or I don't know.
So it can be a real tricky subject. It can be a real tricky subject because actually, if you ask a group of people, half the room will go, he has the right to know. And the other half of the group will go, I don't think it's down to us. I need to mute that. It's not down to us. You know, there's other people that could say, I don't think it's our responsibility. The point with ethics is there's no necessarily right or wrong answers. It's about an argument. It's about what's morally and ethically right. So we'll have a look at this. But the core principles to ethics is, are we treating people with dignity? Are we making them, do they have informed consent? Are we respecting confidentiality? Are we taking into account privacy? Truth-telling, which I think you all agreed on. Autonomy, so the right to manage our lives. Benevolence, so in other words, we're following a set of rules. And non-maleficence, meaning to do no harm. Okay, so they're the core principles to ethics. So dignity just refers to, you know, treating people in a personal-centered way, listening to who they are and allowing them to arrive at their own decisions, okay? Informed consent is about giving people enough information to make a decision. Confidentiality looks at protecting, informing, providing choice, and improving the way that we talk. Privacy is obviously the right to determine the information that we hold around people. Truth-telling is based on the argument that lying is wrong. However, there is an argument on the right not to know. So in this situation, is there a right not to know? So do we think that this person, even though he's asked, am I dying, is it appropriate for us to tell him at that particular point? Would it cause harm for him to know, or does it not cause any harm for him to know? So
cause harm, I think.
It may cause harm, but equally it may not. So the reality here is he may say, am I dying? That gives me time to plan. It gives me the chance to talk to people. It gives me an opportunity to put my affairs in order. Equally, he might think, well, if I'm dying, I'm just going to take an overdose now and kill myself. So is there an argument for the right to know versus the right not to know? It's a real ethical dilemma. Okay, so we need to then not only take into this, but we need to take into all of the other accounts. Autonomy is the right to self-govern. So the right to manage your own information, be in charge of your own decisions. Benevolence is a set of principles. Okay, so a set of principles here, for example, in dementia care, is we have all agreed that lying to somebody with dementia is the best way to be. So if somebody's mum, you know, where's my mum? Where's my mum? We're not going to say, look, your mum passed away 40 years ago. We all normally say your mum's at the shop, or your mum's popped out, or your mum's a little busy at the moment. We go along with it, don't we? Because we know truth-telling causes more harm than good. But that is a set of principles that we have agreed in society. Yeah? Non-malevolence is the fact that I'm not going to cause you any further harm. Okay, so if we go back to the question, which is, do we tell Bob? Do we not tell Bob? We need to look at a much wider piece of work before we come out and say something. So what we might say to Bob in that incident is, you know, Bob, I can't answer that at the moment because I need to find out some things, or I'm not the best person that can answer that. However, I will get back to you. And it gives you an opportunity to do that wider piece of work, which is, you know, is he able to understand? Does he have full control over his life? Is this going to put him at risk if I tell him? Or have you already had that discussion with him where he's already turned around and said, I just need to know because I want to sort my will out. I just want to talk to my family. I just want to plan my funeral. Because you wouldn't want to be the one that robs somebody of that opportunity, but equally you wouldn't be the person that caused him to kill himself, would you? So it's a real challenge. It doesn't end there, because we then follow the ethical practices, the ethical theories. So we've got 3 theorists here that you must know. So you must learn this, okay? So you must learn those 6 and you must learn these 3 theories, okay? Because it underpins all of your decision-making in nursing. So the virtuous theory is all about morality, doing the right thing, okay? So that's the first theory, being that we're honourable people, we're being honest, we're being brave, and we're doing what is right. Okay, so it almost goes under that category of the 6 C's of courage, always standing up, doing the right thing. The next theory is a clear set of rules. So if somebody says to you, why have you done that? You could say, if it's something that you disagree with, you could say, look, I disagree with this. I'm doing it because it's a clear set of rules. Dentology, I can't ever say this one properly, but anyway, it's there. So for example, you might have a strong belief system about something, but you're going to do the opposite, not because you agree or disagree, but because that's the clear set of rules. That's why we're doing it. You're not doing it because it's what you want to do. You're doing it because it's the letter of the law. It's something that you have to follow, okay? For example, lying to somebody with dementia. You may not agree that lying to people with dementia is the right way to go, but we do it because that's what that theory is. And this last theory is all about making sure that your actions bring more benefits than harm. So when you make a decision, can you prove that there is more benefits than harm? Okay, so if we think about some things here, and we'll have a quick discussion on this one. You've got a dying patient and you're in a hospital ward. The patient says to you, can I go upstairs on the roof for a cigarette? Or can I go outside for a cigarette? All hospital grounds are no smoking. But they've asked you, can you take me outside for a cigarette? What would you do?
It might be dangerous. So I'm thinking
Yeah.
about
I get consent to go with him in a smoking area.
Okay, so let's look at let's go back to that. So can I go for a cigarette? So let's look at dignity first. This is your life. This is your decision. This is something you've always done. Actually, you're an adult. You know. So I'm not going to lecture you. I'm not going to say to you, smoking's bad for you, because that's not treating people with dignity. You know the risks, fine. Informed consent. So this is the problem. If I take you outside, what are the risks? What could happen? Can you understand this? But if you're not detained, there's no reason why you can't, right? Doctors may say, we don't advise this, but it's your choice. Okay, confidentiality. Okay, he may not want people to know that that's what he's doing, but you're not going to be writing it everywhere. Privacy. You might have a problem around maybe his dress code. If he's laying in a hospital bed, you've got to push the bed out. How are you going to maintain that? So I suppose you can have a blanket or whatever. Truth telling. It could be, look, we're in an NHS hospital. We don't allow smoking on the grounds. So the only way we can do this is I would have to put you in a wheelchair and take you off the grounds. That would be truth telling. You may be an anti-smoker, and if you're an anti-smoker, you're not going to encourage it, are you? Because that's against your set of values. But truth telling there. Autonomy, he has the right to that request, doesn't he? And I think it becomes more emotive or motive when somebody's dying, if it's a dying wish. Because we always feel compelled, don't we, to feel dying wishes. If it's something we can do, we're compelled to do it. Benevolence. So what are the clear sets of rules? Well, the rules are you can't smoke on the hospital grounds. So technically, we would have to get him off the hospital grounds there. But non-maleficence, so does it cause him any further harm or distress? And that's probably going to be the deal breaker, isn't it? Because yes, he's end of life, but would that cigarette cause a respiratory problem? Would it be the tipping point? Is that the thing that's going to tip him over the edge? So whilst we all want to give him that cigarette, is it going to cause him more harm? Will that be the trigger? So you can see where we all go in, yeah, do you know what? And I was one of these people that would say, I'd stick him in a wheelchair and just take him for a fag. I was one of those people. But now, being a registered nurse, my position has to change because I have to look at all of this before I can come up with that decision. And the reality is, and as sad as it is, it would probably be, no, I'm sorry, we can't do that. Even though you'd want to do it. But that's the NHS. Be different in your homes, because your homes, you could probably go outside, right? But in the NHS, it's no smoking. But if we go to then the three theories, okay, so the three theories is being honest, brave, and courageous could mean the complete opposite, couldn't it? It could mean the fact that I don't agree with that rule and I think he has the right to his cigarette. That could be being brave, couldn't it? You know, pushing the boundaries, trying to make sure people get their last wishes. The problem that I've got there, does it then follow the other two? Am I following this clear set of rules? No, I'm not. I'm breaking that because the rules are there. It says you can't do it. And equally, the last one, would this cause him more harm than good? And the answer is it probably would cause him more harm than good. Even though it's a cigarette and even though he's dying, that action could cause more harm than good, couldn't it? So it makes it really difficult now. So in your mind, you can start arguing with yourself going, does all of that outweigh or does it not outweigh? So when we make decisions for people, when we look at ethical dilemmas, and more so in dementia care, this is where we sit. Another one could be, you've got a vegetarian or a vegan in your care. They've been vegetarian their whole life. They've got dementia, they pick up the sausage and they start eating it. What do you do?
We have to think again about everything. Just take everything and think about it and then decide.
Meanwhile, they've munched on that sausage and it's all gone. It's really hard, isn't it? Because what we're saying is, what the difference between you guys at level 5 and me as a nurse at level 6 is this process, the decision-making process. And the reality is, my brain goes, look, it's a sausage. It's not going to kill them. It's not going to cause them harm. Actually, me tackling them, me trying to raise this could make them feel bad. It could make them feel quite sick because they may in their mind just think it's a vegetarian sausage. Me raising the awareness could actually repulse them, couldn't it? And make them feel, so therefore it could do more harm than good. But if I don't tell them, I'm lying. But equally, do they have the right not to know? Is it going to cause more harm than good? And these are the types of things at work that as teams of people you should be talking about. You know, if you want to have a proper debate with somebody, these are the types of things you can have debates about because they're quite powerful things, because they're really emotive on either side. And the reason they're called ethical dilemmas is because in law, you could argue it both sides. So there's no necessarily right or wrongs. But equally, when we look at safeguarding, we follow those 6 ethical principles and those 3 ethical theories. So it really does underpin the thinking, the philosophy of nursing and social care. Yeah, happy with that? Gets quite deep, but you're never all going to agree on it. You will go around, you're going to find people that agree with you or disagree with you. Equally, we follow professional codes of practices. So arguably that set of rules, and those come from our regulatory bodies, they come from CQC, they come from our codes of practices, the NMC, the health and care professionals, or the general social care councils. So there are guidance on what we do is right or wrong. So there, it's really important that you have read at least one set of codes of practice. When you do your professional discussion in your assessment, you have to recite something from a code of practice. So you need to pick one of these and just become familiar with it. So if you're wanting to go into nursing, if you do want to practice nursing, read the NMC. If you're quite happy and you don't want to go into nursing, you're quite happy to stick on the level 5, read the General Social Care Council ones. But you do need to pick one, because as you talk about things in your professional discussion, you should be linking those into conversation with me. You should be saying, look, Steve, ultimately, in our code of practice, it says this. So what we're doing here under ethics, and it's a bit weird that we've linked it into dementia, but a lot of what we do in dementia care is ethical. We're doing best interests. And when we talk about interest, this is kind of where we're going. You must be able to defend decisions in which you make. So if you can defend it under principles of ethics, that's great. If you can defend it under the theoretical framework, even better. But if you can defend it under a code of practice, you're going to always win your arguments with people. Okay. Right. And finally, before we stop for lunch, I think this is the best description of what dementia is. And apologies if you've already seen this under Dementia Friends. But if you work in dementia care, this is something either you need to learn so you can explain it to people, or just know where to find it and forward it on. Because I think this little video saves so much pain and suffering to family members when they go, why am I bothering? My mum doesn't remember me, why am I bothering? And equally, this also does a really good job at why people come to you. And when you've got those carers, or you've got those patients where the service user doesn't like that staff member, especially in dementia care, this gives you a bit of insight to maybe what's going on.
Hi, I'd like to explain dementia to you in the way that it was explained to me. I'd like to picture that I'm an 80-year-old woman standing here, and that beside me there is a bookcase that's as tall as I am and is filled with books. Now, each of those books represents a fact or a date or a number or a memory that I've gained in the last 80 years of my life. So right at the top, my most recent memory, so what I had for breakfast, getting dressed this morning. The next shelf down might be things that are a little bit less recent. So maybe my last holiday, what I did at Christmas, maybe the last time you came to visit me. The next shelf down by my shoulders will be my 70s, my 60s, my 50s, my 20s will be down by my knees, and my childhood memories will be all the way down by my feet. So that is the bookcase that makes up me. Now, when I get hit by dementia, what's going to happen is that my bookcase is going to start to rock. And I'm going to start losing those books, starting from the ones on the top, which may explain why my short-term memory is likely to be affected first. So as my dementia progresses, I might find myself having lost not only the top shelf, but the next one down and the next. I might find myself living in the 1950s. Now embrace my reality. I go into my kitchen today to make myself a cup of tea. What do you think? Given that I'm expecting a 1950s kitchen, what's a likely accident that I might have? If you thought putting an electric kettle on a hob, that's absolutely right. Now, as my carer, as my relative, you might be tempted to say, we shouldn't let her make tea anymore, that's really dangerous. But there is a simpler solution, which might be to just change my kettle from an electric one to a whistling kettle, because that's what I'm expecting, and I know how to use that. And I learned how to use a whistling kettle all the way down in my childhood, so that memory is likely to stay with me a lot longer. That's not going to help everybody with dementia, but it might help me at this particular stage. Now, I talked about this one bookcase that's got all these facts and memories and numbers, and that's quite a flimsy bookcase, and when that gets hit by dementia, it rocks a lot. Now, this bookcase is representing a part of my brain called the hippocampus, which is more susceptible to dementia. However, my feelings and my emotions, the things that make me who I am and the reasons why you love me, they're all managed separately by a different part of the brain called the amygdala. And that's all here in a separate bookcase. It's a really strong oak bookcase. When that gets hit by dementia, it's not going to move very much. Let me explain to you how the two bookcases work together. So when I was a child, I had a teacher. He's on the hippocampus bookcase. He was incredibly inspiring. And the way that he made me feel, inspired, in awe, that is stored in a separate book on my amygdala bookcase. So the teacher is on the hippocampus, but the way I felt, that's going to be managed by the amygdala. Now let's bring it back to today, where I'm the 80-year-old woman. I have dementia. You come to visit me. So that's a fact, that happens here. And we have a blazing wrap. I'm probably going to feel upset, sad, angry, and that's going to go onto the amygdala and a book here. You might go away thinking, it doesn't really matter. She'll forget that I even came to visit, let alone that we had a row. And you know what? You're probably right. That book will probably go. But what's likely to stay with me are those feelings, those emotions, that anger, and with nothing to relate it to. It might be really confusing for me. But let me leave you with a positive example. Say you come to visit me and you take me out to the seaside and we have a great time. So here it is, the seaside, the waves, the great time, the feelings of safety and happiness and love that I feel are held over here in the amygdala. As soon as we get back to my house, I've forgotten where we've been. That book is gone. And you might think, oh, it's just not worth it. Why do I bother? I don't think I'm going to carry on visiting her. But look over here. Those feelings, that safety, that warmth, that's going to stay with me for a lot longer. So I would like to encourage you to continue to visit and to care for the people that you know, relatives, friends who have dementia, and to remember that there is more to the person than dementia. Thank you.
And I think that's a really lovely way of summarising it for people to understand. So when relatives come in and go, I just don't see the point, and you see it all the time, don't you, with relatives, they just give up hope. By showing them that, I think it leaves them with a bit of hope that actually it is worthwhile carrying on. And for the relative, it's you know, it gives them a bit of hope as well, because it means all of those feelings, all of that emotion, all of that care that you're giving isn't going to waste. They are storing it. But conversely, it then makes me wonder, as a safeguarding nurse, if I put my safeguarding hat on, when you've got those carers that go, oh, she's always mean to me, she's always mean to me, she's always mean to me. Why is that? Is it because actually you haven't provided care that has connected with that person? They haven't felt safe and loved. So they don't know who you are, but what they do know is that you've got a bad attitude. You just haven't come across as kind or caring. You've rushed the care. You've made them feel terrible. So they've connected that feeling with you, but they forget who you are. So I always find it fascinating how in care with dementia, there are some carers that are swamped by patients because you're kind, caring and loving. And you've got those other carers who can't seem to work with certain people. So it makes you wonder, doesn't it, about that memory. Okay, you know, you could say something horrible to somebody, they're not going to remember it, are they? But that feeling remains there, so they can't put their finger on it. And I think you see that all the time. You know, in care, when you do those extra little bits, when you put that lipstick on somebody and you talk about something, or you do their hair or you do their nails, they remember that. And they just connect to you more, don't they? They don't know why. And a lot of the time they go, oh, you remind me of my daughter. And I think that's, or my son, that's the biggest compliment you can get in nursing, because that's somebody that they loved and trusted, and your behavior reminds them of that safety. So I think that's a really important takeaway. And for people that are new to care, I think they should always watch that, because I think that sends a really strong message about, just because people forget who you are, don't change the way that you act or behave, because it is stored in the amygdala bookcase. So let's stop for lunch. Shall we come back for 1:15? And this afternoon we've got dementia. No, we've done dementia. Look, there's my memory loss already. We've only just finished the topic. We've got insulin, epilepsy, stroke, arthritis, and one other that I can't remember. So my short-term memory is being played up. So we'll see you all in half an hour.